All right. Hello, everyone, and thank you for joining. My name is Sadie Bejer-Lady. I work as a Senior Program Associate with the Mental Health Program at the Carter Center. We're really excited for today's event, so thank you for being here. We're incredibly pleased to welcome you to today's session, Mental Health and COVID-19, Advancing an Integrated Response in Liberia and globally. I'll share a couple of housekeeping announcements before we begin. We'll have two back-to-back panel discussions today with time reserved for questions at the end of both panel discussions. Please use the chat box feature to ask questions as they arise during the session. We'll keep a record of questions asked to share with the speakers to provide an opportunity for further and ongoing discussion following the session today. And finally, please know that we will be recording the session. Without further ado, I'd like to introduce Dr. Eve Bird, Director of the Carter Center's Mental Health Program. Welcome, Eve.
Thanks, Sadie. Good day, everyone. Happy belated World Mental Health Day to you all. We welcome you to this conversation at a time when health and mental health are on the minds of so many, and are so appreciative of you joining us today amidst the Zoom fatigue that we're all experiencing and the countless other things you have having to manage daily. Today's virtual event is about the integrated mental health and COVID responses, which are needed globally now. The session will unpack efforts in Liberia, which have ensured that mental health is a key component of COVID response policies and programs, and a great group of panelists will talk more about the opportunities and challenges in addressing mental health during the pandemic in Liberia, as well as in Sierra Leone and Haiti. I want to welcome my colleagues. We're eager to have this conversation for a few reasons. First, the unique and enduring challenges brought on by COVID-19 have left many managing higher levels of stress, anxiety, depression, and grief. Disruption to services and access to care have further exacerbated poor health, mental health, and disability. Therefore, the need to share our efforts and experiences from the past few months and learn from one another is more crucial than ever. Building our collective understanding of how to manage, cope with, and recover from this uncertain and impactful pandemic will help us all go far together. Secondly, despite the devastating impacts of COVID-19 and guidance to address the mental health dimension, how organizations and governments integrate mental health and national COVID response is still less clear. The Carter Center Mental Health Program has been an advocate of mental health and well-being globally with a decade-long engagement in Liberia that's resulted in significant programmatic and policy gains. Our experience in working to prioritize mental health in Liberia, first during Ebola and now during COVID, has helped bring clarity to us in how this works in practice that we think we should and would be useful to share with others. We also look forward to your sharing your expertise in this area. Lastly, this conversation aims to reinforce and build on the momentum of global health messaging, that mental health is core to overall health and well-being and needs to be prioritized, invested in multi-sectorally, even and most especially during times of crisis. Mental health and psychosocial supports are vital for both frontline workers and the people they serve. With that, I want to introduce my colleague, Dr. Janice Cooper, the Carter Center's Senior Project Advisor for Global Behavioral Health. Dr. Cooper will share more about the origins of her work in health crisis response. Thanks, Janice.
Thank you, Eve. My name is Janice Cooper, and I work here in Liberia and have been working with the Liberia Mental Health Program for 10 years. I wanted to talk a little bit about the system of care that we have worked on developing with the Ministry of Health. And since 2019, the Liberia Mental Health Program has really been in partnership with the Ministry of Health, and it was the Ministry of Health and Social Welfare, and now our other partners are the Ministry of Gender, Children, and Social Protection, and with our county health system. And that foundation, I believe, suited us well for when we came to grappling with Ebola and the Ebola crisis and its aftermath. And it really led us, by the utilization of the mental health clinicians that we have trained, we trained over, with the government of Liberia and the Ministry of Health, over 340 mental health clinicians. And that foundation really set us up well for a building back better strategy that we try to employ post-Ebola. And I think ultimately it led to the strengthening of the system of, and I would be remiss if I did not talk about some of our other partners who are in the work, like Liberia Association for Psychosocial Workers, Liberia Association of Mental Health Practitioners, Cultivation for Users Hope, which is our mental health service user organization, and many international partners, some of whom are on this call, like MSF, for example. So like Liberia and Sierra Leone and Guinea, Liberia tried to use our experiences from Ebola to build a better system of care for mental health. And today, I think you will hear about that. You will hear about issues of how persons who have lived mental health experience were at the forefront of even our COVID response. So I'll hand you back to Sadie now. Thank you.
Thank you, Janice, for the overview and the introduction. Thank you, Dr. Bird. I will now pass it to Ben. Welcome, Benedict Dosen.
Thank you very much, Sadie. And thank you, Dr. Cooper and Eve, for the excellent background. Good morning, good afternoon, good evening, wherever you are. My name is Benedict Dawson, and I'm the program lead for the Cardo Center Mental Health Program here in Liberia. My overall responsibility is to oversee the center's behavioral health initiatives in the country in support of a sustainable and qualified mental health workforce, implementation of the mental health law and policy, and promotion of human rights and social inclusion. 2020 has been a difficult year for the entire world, particularly due to COVID-19, which has ravaged almost every health system. With the aim of understanding better how COVID has impacted mental health service and what works when integrating mental health into emergency, we are honored to host this learning event. The event is intended to help us share country experiences with integrated mental health in COVID response, while drawing parallels with other emergencies. To learn about opportunities and challenges in addressing the mental and psychological impact of COVID health crisis, and also to shed light on the Cardo Center work in Liberia in the context of COVID and Ebola. Since the emergence of COVID in Liberia, the center has been committed to supporting the implementation of a comprehensive, robust, and efficient preparedness and response through partnership with the government of Liberia, as Dr. Cooper explained, and as a member of the incident management system. Serving on the mental health and psychosocial support pillar, the center has supported the development and implementation of key policy documents, clinical management tools, and referral plans. In collaboration with line ministries, local agencies, INGOs, and even UN partners, the center has trained healthcare workers, social workers, and psychosocial support workers in mental health and psychosocial support to help people affected by COVID, be it in the treatment centers, precautionary observation centers, or communities. Community health volunteers working with the Monserrado County Health Team have also benefited from training on psychological first aid under the auspices of the center to enhance their work in contact tracing. Now, as Dr. Cooper explained, Ebola sort of set the stage for us. So coming from Ebola and going through COVID-19, Liberia has learned a lot and made some progress. While we must commend the elevated platform that mental health and psychosocial support have gained over the years, we know that there's still more work to be done. Some efforts have been effective and others have not. In Liberia, apart from boosting the number of mental health professionals, the greatest achievement can also be said to be on paper, like the policy, legislation, strategic plans, etc. while implementation and service delivery are stagnant. Sadly, COVID continues to devastate the entire world. Though the number of reported cases in our region is not very high compared to other regions, the repercussions are severe for us. Every sector, health, the economy, education, is struggling. Hence, it is important for us to assess and reassess our strategies and share experiences as members of the global community so that we can fight this pandemic better. Today, we will hear from experts with unique roles and experiences in the COVID health crisis in their countries, Sierra Leone, Haiti, and Liberia. As the moderator, I will be guiding us through the process. I will introduce the first panel members briefly and ask them to make their opening statements, after which I will take a deeper dive into the content with follow-up questions. We'll follow the same process for the second panel, and then I will summarize lessons learned and open the floor to the audience by asking questions they have submitted via the message board, as Sadie explained. So let's start with our first panel. The theme for this panel is integrating mental health in Liberia's COVID response. All our panel members are from Liberia. I would like to first start with Dr. Yata Juapo. Dr. Juapo is a physician and a public health specialist. She earned her master's degree in public health in healthcare policy and management from Cardo University in Liberia, and her medical degree from the University of Liberia. Dr. Juapo works for the Ministry of Health as the County Health Officer of Montserrado County, and she is the Incident Commander of the Montserrado Incident Management System at the sub-national level, leading the COVID-19 response. Our second panel member is Sadia Mawulu. Sadia is a registered nurse and a COVID-19 survivor. She earned her bachelor's degree in professional nursing from the Smythe Institute of Management and Technology in Liberia. Sadia has been a nurse at the John F. Kennedy Medical Center in Liberia since 2016. Our last panel member is Josephine Kawa. Josephine is also a nurse. She's a mother and current volunteer on the COVID-19 response in Liberia. She earned her degrees in biology and chemistry from the University of Liberia. She lost both of her parents to the deadly Ebola virus that, she says, tragically took away many lives in Liberia. She relates her experiences with Ebola virus to support the current COVID-19 response. So those are our three panel members, and I will be giving them the opportunity to talk more about their stories and present their opening statement. For the opening statement, each panel member will have 5 minutes to make that. And again, we have to keep to the topic, integrating mental health in Liberia's COVID-19 response. And after that, panel member will have about 2 minutes to respond to follow-up questions. So I would first like to begin with Dr. Juapo. Dr. Juapo, can you tell us about the situation with COVID in Liberia and what your experiences are with integrating mental health in the response?
Thank you, Mr. Dawson, and hello to everyone. Thank you for having me. As you said, my name is Yata Juapo, and I work for the government of Liberia. I'm a county health officer. As you rightly said, I have been in this role for the last 5 years. Interestingly, when I became a county health officer, I know I'm sticking to what we're talking here, but I just wanted to go back a little bit and say that when I took over as a county health officer, we still had Ebola in Liberia. And when I took over 5 days later, we had a second wave in the Duporo area. That was, it was a reawakening public health for me in what everything meant to be a county health officer. I had to relearn everything and learn how to coordinate with partners and all of that. Coming back to COVID, currently in Liberia, as you are all aware, I will give the statistics for as of the 21st of October. We currently have a total of 1,385 as of the 21st. Today we have new numbers, and I will explain why we have increase in different numbers. And Monserrate County remain the epicenter. We accounts for 69% of the total cases that we have in Monserrate County, which is 965 as of the 21st. The role of mental health in the COVID-19 response, and Dr. Cooper will know, and Dawson will know that we have been fighting. It has been a fight actually to get mental health a face in everything we do in Liberia, especially with COVID. Initially, mental health was just placed under one pillow, and then we started the preparedness in January, and then people started all of the preparation. In fact, in January, someone once asked me, Dr. Juapo, are we responding to COVID or are we just preparing? And then we laughed. But it was good that we started to prepare as we did, because from lessons learned from Ebola, we're able to use those lessons that we learned during the EVD period to prepare as early as January, when we started to have students come back from China, and we have people come back from affected countries. So in one of our IMS meetings, I told them that mental health cannot be under case management, even though it's case management, but mental health should be a stand-alone pillow. And we started the fight. And then we finally was able to be successful, and then mental health was granted the permission to be a stand-alone pillow, the mental health and the psychosocial pillow. And even at that, the only partner at that point that we really have was the Cardo Center. And the Cardo Center was supportive in helping the mental health pillow, in guiding the whole process. And then later on, we had other partners, like I think UNICEF came on board also to support. But it has been a roller coaster ride, and with people understanding that mental health clinicians should even be in the treatment unit, mental health clinicians should be working alongside the response team. Mental health clinicians should be actually helping us to guide the whole process as we get people out of the community. Because at one point in time, we even decided to employ police, to have the police go along with our teams to get these people out of the community, because in Liberia, we have a whole policy, and part of what we do states that we have to identify all confirmed cases and isolate them, take them to treatment unit, identify their high-risk contacts as well, and take them into precautionary observation centers where they will remain. And if they develop signs and symptoms, they will be moved also to treatment unit. And in order to do that, the mental health and psychosocial unit, they play a very important role. I would say as a county health team or as an incident manager, I was successful only because I had a very strong mental health and psychosocial team by my side. And thanks to Benedict, because I remember I took a short break, like 2 weeks break, and then by the 16th of March, we had our first case, and then I got a call, Dr. Juapo, where you are, reports right now. So I had to come, but then we didn't have anything, we were preparing, but we did not have the response plan actually in place. And then I reached out to Benedict, and he said, hey, Dr. Juapo, we have some funding, is it possible for us to, organize something quick? And then the Cardo Center again was the first partner to really stand by me to train community health workers. And by then we gave our mental health and psychosocial clinicians some refresher training so that we could start to really respond to our COVID activities here in Monserrate County. So for now, that's just a brief synopsis of where we are with the mental health piece. And I can do with all my mental health and psychosocial people. So over to you, Benedict. If I still have some time, I can talk more, but I will stop
I will
there.
come back to you. I will come back to you. Thank you very much, Dr. Juapo. Excellent sharing. But yeah, we have some follow-up questions, so we'll come back to you. And I just want to encourage the audience down to start to follow up and submit their questions through the message board so that we'll make sure you have an opportunity to be heard. And so, yeah, it will be good now to move to Sadia. Because Sadia is a health worker and also a COVID survivor. So in the early stages, she had her own experience. So Sadia, I would like you to kindly share your personal experience relating to being affected by the crisis and responding to the crisis.
Hello, everyone. Mistress Sadia S. Maolo. I'm a nurse. I work at John F. Kennedy Maternity Center. I'm a son at the NICU. I'm a mother of 3 children. I was tested positive for COVID-19 and I bless God I'm a survivor. During the COVID-19, I heard the first case of COVID-19 in Liberia. I got so afraid because I was pregnant and I thought back on what happened during the Ebola time. I was also pregnant during the Ebola time. And learning that there's another virus killing people all around the world and I was pregnant, I was so afraid. It was this day that I went to work and they had a few hours workshop educating on us on the preventive measure of COVID-19. And then I learned that pregnant women was at risk. So I got so afraid. But then I kept on working because there was no way that I could stop working because the shortage of staff at the facility. So this day, when I went to work, I worked with a doctor and I went home for 2 days off. When I came back, no one. And then later on, my bosses called me and told me, said, yeah, you need to go home because the cases are increasing. And then I went for ANC visit. From there, I went home. During the late hour by 8 p.m., I started to receive calls from my friends then asking me how I was doing. And then I told them that I was all right, but then calls just keep on coming in. Later on, someone told me, oh, they said they are quarantining you people. I said, what? I just heard it. She said, they said they are quarantining you because you work with a doctor that is now tested positive for COVID-19. And I got so afraid. I went to my husband and told him. And then I called my friend that we work together. She said she was going to get tested at the football field where they were testing people. And then the next day, I too went to get my test done. And a few days later, I went for ANC visit. After the ANC visit, I was on my way home in the bus when I received this strange call, a lady identifying herself as a worker from the testing center, and she wanted to speak to me privately. So I told her that I was in the bus with other people, and then when I get home, I would give her a call, and she said, okay. On my way going home, there was a bridge before my junction. There was a checkpoint that was there, and then our bus had to stop. There was an ambulance approaching the bus. So I got so afraid. I said, why would I receive call from this woman and now seeing that our bus had been stopped and an ambulance approaching the bus? So maybe they are going to take me away. I was so worried, so scared of me going to die and not seeing my family any longer. And so the ambulance came and passed. And I'm taking a deep breath because knowing that the ambulance was not coming for me. When I got at the junction, there was people standing all there. When I got down, they started staring at me. So I went, I washed my hair and then did my time. It was 37 point something. I just can't remember, but I saw the 2 first numbers. So while going in the estate, I saw this car, this Jeep pack register waiting on the COVID-19 response. And there were a group of people standing by with their COVID-19 vest on, just staring at me. So I didn't say anything. I kept on walking with fear in my heart. I was so light. I couldn't even feel my hands anymore on my feet. I just kept on walking. Ahead of me was the same people in the COVID-19 jacket. And then the other men were communicating on the phone. Approaching him, I just heard this engine race behind me. When I turned around, it was a COVID-19 Jeep that engine they were racing. So I thought they were trying to stop me. When I turned around, No one said anything to me. I kept on walking. Almost at my house, there was this lady who said, oh, I was worried about you. And I told her, I'm okay. But then I started thinking, what would this lady say she worried about me? But I kept on walking. I got home, washing my hands at the door. My husband said, oh, Mama, how are you? I said, I'm okay, but I received a call. And he said, yes, just wash your hands and come in. Well, when he said, sit down, let them bring food for you to eat, and then try to take a bath. So I said, I have no appetite to eat. I received a call and getting me scared. This woman is from the testing center. And he said, yes, I know, just eat. I said, why would you say yes, you know? Did they call you or what? He said, they came here. They came here, they were looking for you all over in the estate. They even had your name on radio that you are tested positive and they are in search of you. So I said, how will they do that? I gave them my phone number, my address, everything. They didn't contact me till today. So he said, yes, so they've been passing from house to house asking for Sedia Mauro. When they came here, I told them that you are my wife. So they said they will come back. So later on, I was taken back when they came, and my son came to inform me. He said, oh, the people are here again. Then outside, they're talking about our daddy. So I already took back. When I met them, they were not in the house with us. They were standing outside of the house in the yard and speaking to my husband. Later on, they asked me to step forward to ask me some questions. When I got on the porch, I saw my entire community staring at my house as if to say somebody had died there. I was so afraid, so frightened that I told them that I didn't want to go anywhere to go and suffer. And they said, no, we'll take good care of you. So I was then informed that they were not going to be the one to take me away. It was going to be another team that would come later on to take me away. So by some minutes after 8 during the night hour, I saw ambulances with jeep and a lot of people in PPE came to get me away. It was then that I learned that they were taking my husband away too. I said, well, how will you people inform us just not like taking my husband away? Who will look after my children? My sister is here with her children and my brother, they too have to go to their houses too. And I said, no, your husband we are taking your husband to another place. So my husband said, but I thought since you decided to take me away, maybe you are going to take me to take care of my wife in her condition. And they said, no, we are taking you to another place. So I fought her, I got in the ambulance, but there was no seat belt to even help me to keep me in position so that I won't fall. As the ambulance was going, I was trying to balance myself and they almost ran into a truck. So I was so afraid. They took me to this unknown destination, somewhere I've never been before. And when they took me to this room, there was a lady that was there who was also positive. 2 days later, this woman was discharged and they brought in another positive person who had all the signs and symptoms of COVID-19. And I got so frightened, I started crying, I started calling, and my friends calling, family members calling the doctors and to tell them that I couldn't be in this room with this woman who had all the signs and symptoms due to my condition. And then told me that it was not going to do anything to me, that they can't change the woman room because she just have to be there with me. I should calm myself down. Later on, I brought in another patient again who was also tested positive, and there were 3 in the room. So I got so afraid. Later on, I couldn't feel my baby moving in my stomach. There was no fetal movement. I got weak at the point I went to go take bath one day, and then I was like going.
Sadia,
Yeah.
can you hear me? Yes, yeah. Sorry. I know it's interesting. We'd really like to follow up with the full story. But at this time, we've gone 8 minutes now. So maybe if we move on and we still have time, then you have the opportunity to talk more. Or when we address a subsequent follow-up question, then you can explain.
Okay.
But so yeah, I will give you 1 minute to wrap up, Sadia. Take 1 minute to wrap up.
Yeah, at the treatment center, they were not prepared for a pregnant woman. There was nothing there to examine me. There was no midwife, no doctor to go there to take care of me. I kept on not feeding my baby movement. I kept on calling, and it took long, over a week plus before. And there was this lady who called Javier Monday from the UNFPA, and they came in and provided Doppler and other things to help me. Even the food was not correct. The environment was not conducive. There was no privacy. The food was not correct. I had to be calling for food outside, crying to people to help me with food because the food they were preparing was not all right for a pregnant woman. And everything there was not just for a woman in my condition of being pregnant. So the fear of losing my baby, it was very hard. I couldn't feed my calling, kept on asking them to send somebody to check me, to check on my baby, and there was nothing done there later on.
Okay.
So it was very bad.
Yes. So sorry. It's a very sad experience. But we'll take now our next speaker, Josephine. Josephine, I would like you to respond to the same question I asked Sadia and share with us your personal experience relating to the crisis, how you are affected and how you're currently responding.
Good morning and good afternoon, everyone. I'm Josephine D. Kawa, a BSc holder in biology, major and minor in chemistry, and also a registered nurse. And I also volunteer with the COVID-19 response in Liberia. Back there in 2014, my family came in contact with the deadly Ebola virus, where my uncle who interacted with a church member, and unknowingly my father and mother, my both parents went there to give care, and they came down with the virus. But before then, we never had the actual knowledge of how this virus worked in Liberia because the media never provide the adequate information that we really needed. So we all were in denial. But then it's not possible for the whole family to get sick at the same time. So when my whole family took sick, including me, and I was 6 months pregnant at the time, and also have a 3-year-old daughter, then we decided to call the ambulance. And we called the ambulance, it took 10 days. They could not respond to us at the time because they were using car going around collecting dead body or so. So my brother decided to take us one at a time at the ETU. And when we got there at MSF at the time, the treatment unit was still under construction. We remained there and we were admitted. After 2 days, my father died. And the following day, the next day, my mother died. And I was sitting that evening, Ebola positive, my sister positive, even our last born were also positive because the whole family were taken there. And I saw my both parents' names being labeled on the body bag. That was my first time seeing body bag since I was born. So they were labeled on the body bag, Sam Kawa, Josephine, and Sanke Kawa. So I was like, what's going on? And I went there to watch my parents being sprayed, put into the body bag, and I asked them what was also going on. They said they were taking them for cremation. And for our culture in Liberia here, we don't cremate body. We bury our remains, and we have a holiday where we go and let's say and present flowers to our loved one that we miss and so. But then they were taking them to be cremated. So I lost my memory. I could not remember Monday from Tuesday or even days or night. I started sleeping outside. As people say, I was sleeping outside. I was naked because I was confused. I did not know what really were going through. Even I had a phone where my family member would call and I would tell them wrong number because I could not remember anyone. I could not remember anything. And I remained there until a time came where I had a long sleep. When I got up, I felt I was also naked. And I also forget I was even pregnant. So it was a doctor that told me in a treatment unit, but Josephine, you are pregnant and you need to stop sleeping outside and you need to eat your food. Before I even realized that I was also pregnant at the time. But then on this fateful day, September 4th, 2014, I became negative from the virus. And I was told to go home. I went home, that night, but before I could reach, I called 1 or 2 persons to tell them I was coming home, and the community gathered that I should not enter the community because I just from the treatment center. But actually, I never had nowhere to go. And when I got to my house in Magibi, the county health team had already sprayed my house. There was no mattress, nothing to sleep on. So my family had an unfinished building. That's why I moved. I moved in the unfinished building with a blanket they gave me from the treatment center and so all of that. I decided to sleep. But then I was highly stigmatized by my community. They call me Ebola girl. They call my sister Ebola sister. People refuse to come around. People place my name on Facebook that I was dead. And whereby I was in the house. So I decided that the best place to stay is to go back to the ETU and stay because my community was not helping me at all. So I packed my things that night, waiting for daylight so that I can go back to the ETU on a Sunday. But then by 1 going to 2 aside, I got in labor and the stomach started to hurt because when I got home, I was not sleeping, I was not eating because I was rejected by my community. So I took my certificate and started to walk on the road. Everybody that I asked for a car, they could not help me. And right in the process, I had a miscarriage right on the street at the intersection. There where I had it, and there were a few women that were standing by. They called, Josephine, are you okay? I said yes, but none of them could come around. They just make a cycle around me, and I had a dear child in my hand with another lapper. I wrapped it, and I went home. I myself buried. And then since that time, I was like confused because this thing is very strange to me. To be in such a condition, and there's no one to help. Actually, there is no one. So I was just thinking like all hope is lost. And besides that, I still feel that I carry the virus. Yeah, that's how I feel because people continue to stay away. Until this day, I went to church. I decided to give my testimony for what God has done for me. When I hold the mark, after giving testimony, nobody went there to even testify. The seat that I was sitting in, everybody left the seat. My chair was only alone. And I felt bad. I went home crying because even in the church, if all the community says yes, but even in the church. So that's how it been. But we gave God the glory and we tell God thank you for Cardo Center because they came and they did counseling because I was like not knowing myself actually. So over to you, Benedict.
Thank you so much, Josephine. Story and Sadia's story, and a very revealing. It tells a lot about the negative impact of the virus beyond the physical signs and symptoms, highlighting the serious mental health issues associated with it, highlighting stigma and serious community behavioral issues, and even the unpreparedness of our system to be able to adequately respond to address the crisis. Dr. Juapo, that sort of put something on your plate. I would like to move on now to ask some questions, and I would like to begin with you. So, listening to Josephine's story and also listening to Sadia's story, Sadia first, and coming from the early stages of the outbreak in the country. We know that when everything started, government programs and organizations had work plans and budgets already developed, quite unrelated to COVID-19. What was the situation with getting support to be able to respond in the early stages, and beyond what they described, how did that impact the response and mental health?
Thank you, Benedict. I don't know what to say. So, I would like to say first, sorry to Josephine and to Sadia, because the both of you have very touching stories. And coming back to your question, Benedict, from the beginning of this whole COVID response in Liberia, we had a lot of issues with finances and getting resources to respond adequately as a government. Because as you are aware, most of the programs, you are a partner, and you know that you already had all of your programs set before COVID, because it's difficult to just get up and move lines. You have to write to headquarters, you have to seek permission from your donors before you can, spend money, even if it's an emergency. So initially, the government did not have the funding to carry on this activity. As we are all aware, in fact, we know that I think from the beginning of the year, we were told by our government, our leaders, that we had a lot of economic issues in Liberia. It was not a secret. It was all on national radio that we're going to have a lot of budget cuts, a lot of budget shortfall because of the economic situation that the country was in. So, and looking at our own system, our health system, we know that our health system is like 80% reliant on donor funding. So almost everything we do, 80% of everything we do has to be funded by donors, partners, and even some local NGOs. So to even start to begin to train these people to be able to deploy mental health clinicians and other key pillars that we needed to respond adequately was an issue. We did not have funding. So even if we had someone to help us to train them, we did not have commitment from the government and from other partners to be able to provide them with the resources, logistics, and the incentive-based resources that they would need to continue to respond adequately. In fact, the National Incident Manager always said to me, Dr. Juapo, this is a resource poor response when I go to fight and say, my team have not gotten paid, we don't have fuel, we don't have scratch cards to pour these people. They said, Dr. Juapo, this is a resource poor response. So you have to make use of whatever limited resources we have. And you are not a stranger to this. I know I call you a lot of times. I wrote emails begging around to see how I could get my team together, because if it was not for you and other donor partners that came to my aid, we could not have done it as a county. And we still have challenges even today because this is still a resource poor response.
Okay. Thank you. Thank you very much for the response. And I would like to throw my next question out to Sadia and Josephine. And Josephine, it would be good if you can pick up the question first. So you experienced Ebola and had a very bad experience in the process. Now you are back in the healthcare system and responding in COVID. What's the motivating factor? What has brought you back to remain in the system and work through it?
Thank you, Benedict. One of the factors that really motivated me most is when people you need around you is found. When people you need around you is found, they also give you the strength. It gave you joy. And it gives you consciousness to do whatsoever you want to do. And you will feel love. You will also see yourself going back again to get in a stable condition. But when you have everyone rejecting you, then you will still remain at the same point. But once you find people around willing to support you, talking to you and creating that love, it will definitely, that's what motivated me most.
Thank you. Sadia, what took you back?
Yes, thank you for the question. What took me back to work is the passion of my work. And then I know that many people will need my assistance after my experience with COVID-19. And then they want to see that I move on with my life. So that's why it gave me the hope to go back.
Okay. So briefly, can you talk about what needs to be done after people are discharged? So you explained a lot about the system when you were in there, and then people get discharged and move back to the community. What's your experience with that level of support, and what do you think should be done to help other survivors?
Yeah, what I experienced after I went home, my whole community are afraid of me and my family. Even when people leave from the estate to go to the market to buy, people rejecting their money. They say that the estate have COVID-19 and they didn't want to be part of them. So everybody was pointing at me being the problem. And then up to now, people are still pointing hands at me and saying, oh, that was the be better that was tested positive. And then even my entire family have been stigmatized. My children up to now, they still have dreams of ambulance coming to carry me away, and then they were separated from me. And then right now, since we went home, there have never been any follow-up, no social counseling, no support at all. So they really need to help people, because the mental problem that have been created by COVID-19, we just don't know how we'll get over it. It's very bad.
Okay, Josephine, you want to take 1 minute to address the same question? Like,
yes,
living from such, let's say, sickness or quarantine, I would say that she was, let's say, a pregnant woman living, and likewise myself was a pregnant woman and I left the unit. We should not just be sent home into the community. I could survive from Ebola, but for what I experienced from the community who have killed me, at least they should have an area where the OB that will survive from such areas can be placed, so that they can receive their prenatal care and give and deliver their baby alive, instead of just sending them home. And also they need constant visitation, psychosocial support, community reintegration, not just to send people home, but let the community people be involved. The stakeholders that are in the community know that, oh, Josephine is coming home today, and let there be a welcome. Skill training and other things could also help us in the process when we survive. Okay, thank you. Dr. Juapo, one last question, then we move on to our next panel. So one, can you just point out to a couple of parallels with our Ebola crisis, and then also tell us what changes do we need to make to ensure that integrating mental health in crisis situation is more effective?
Okay, thank you. I did not quite get the first line. Can you repeat?
If you can, with the COVID crisis, like what are the parallels from your experience with COVID and Ebola? Yeah, just a couple to highlight, and then what needs to be done? What do we need to put in place? What are policy plans or anything to make sure that integrating mental health in crisis situation is more effective?
Okay, thank you. Thank you so much again for the question. I think it's very important. So from my experience with the EVD crisis and my experience now with COVID-19, I believe that the government should do more for mental health and psychosocial to be well-grounded and well-integrated in our entire system. One of the most important lessons that we learned, and both of them tried to talk about a little, was to be able to integrate the discharged patients back into the community. So one of the things we started doing was to create a situation where we can have community healing dialogue and have the psychosocial team to go before our patients and have a conversation with the community and explain to them that these people are no longer infectious and all that. But we don't want it to stop after this COVID. We want it to be a part of our system so that people see mental health as a condition. We can't just look at mental health because, you know, as you are all aware in Liberia, most of the times people think mental health condition is associated with witchcraft. So the community needs to understand what mental health is all about. They need to understand that when someone has mental health issue, they can get treated, they can get well. People need to understand this. And when we begin to understand this, we'll change our entire mindset. So one of the things we did at the Fennel POC, where we had high-risk contacts, when these high-risk contacts were being discharged home, we had them, they were being accompanied by mental health clinicians. So the mental health clinicians will go with them to the community, have a meeting with the community, and explain to them that these people are no longer infectious. They reintegrate them into the community, and the community welcome them. So we did not have a lot of issues with stigmatization, with people getting discharged from our POC. And like you said, we have all of the policy document, so we should not just keep it on the table. I'm glad that Anjita is on this call. She's listening in. So I would like to encourage Anjita to work along with the partners and to push the national government so that all of these great documents that we have crafted, we should use them, and we should ensure that we implement them. We shouldn't just write. We should implement them going forward. So thank you so much. I think I will stop here for now. Over to you.
Okay, thank you, Dr. Juapo. Now, we will move on to our second panel. And the theme of this panel is from local to global. Our previous panel shed light from a national perspective. And considering the global scale of COVID, we will move on to talk with experts from Sierra Leone and Haiti. So we know Sierra Leone is next door, but why that is so, experiences in the country might be different. And similarly, Haiti may be far from Liberia, but experiences might be similar or even more enlightening. So we'd like to hear more from our two panel members from Sierra Leone and Haiti, Joshua Duncan and Dr. Lucine Desir. So I would like to introduce first Joshua. Joshua is the head of the Mental Health Coalition in Sierra Leone. He earned his master's degree in public administration and management from Untitled University in Sierra Leone. With over 9 years of experience managing mental health programs, Duncan is an expert in integrating mental health programming into disease outbreak response. Our next panel member is Dr. Lucine Desir. Dr. Desir is a native of Haiti. He earned his medical degree from the Escuela Latinoamericana de Medicina in Havana, Cuba in 2005. He joined the Cardo Center as program manager for the Hispaniola Health Initiative in July 2016. Dr. Desir works with both the Haiti and Dominican Republic Ministry of Health to achieve the goal of elimination of two diseases, lymphatic filariasis and malaria. So to begin, I will throw out the question so that each panel member can make their opening statement. Again, you have 5 minutes for your opening statement. So starting with Joshua, what is the situation of COVID in Sierra Leone, and what is the experience with integrating mental health in the response?
Thank you so much, Benedict, for allowing me to speak on this topic, and lots of appreciation goes to Cardo Center for organizing such a great program. It's also good having Janice Cooper and the rest of the team on board. You know, I want to look at my introduction from a three-pronged approach: the why, the what, and the how. Understanding the why, understanding the what, and understanding the how, can we integrate MHPS into COVID-19 response, the COVID situation in Sierra Leone? Let me quickly start with the quote when I respond to the why. This is what someone says: the situation is not easy. People are worried a lot. There are a lot of things that are happening in Sierra Leone. We, the nurses, are putting everything in place. Even traditional authorities, they are putting everything in place. because the counselors are also worried a lot. There are suspected cases in Guinea, and they are our nearby neighbor. So we worry a lot about the disease. This is a quote, direct quote. So the why integrating MHPS into crisis situation might come as a result of three things. The impact of successful crisis situation has and is still having its toll on the people of Sierra Leone. Yeah, succession of pre, during, and post-traumatic experience in Sierra Leone has been very rapid. Rebel war like in Liberia, Ebola outbreak, mudslide, and all. So the traumatic thought, the traumatic experience in succession is quite an issue. But the other issue around the MHPSS is the impact and the reflective fear, anxiety, anger, worry that the above quotes points at. A lot of people are fearful, they are anxious. What is happening owing to the fact that the devastating effect of Ebola and the reality that COVID is almost worse than Ebola is a whole issue for the people in the country. And the third truth about responding is that lots of first responders focuses mainly on the physical and social, and sometimes material. A little is being placed on the psychosocial or the mental health needs. A little, a lot is just on the physical response. How do we treat? How do they recover? Burning their things, like our dear sister says, so that they might not infect others. But the torture and the trauma, very little organizations, including the government, has not been doing well around that. I want to look at the what. This is another quote that this lady said. We are worried because it will affect our health workers. If there are cases here in Sierra Leone, we are the front liners because we touch patients, we receive patients. So we are worried a lot and hope that it will not spread easily because it is a very dangerous for her. It is a very dangerous disease. And underneath this quote, I brought out the 5 priority action planning guide for COVID-19 in Sierra Leone. And please listen to this priority guide. They firstly said identify rural hospitals with little or no capacity to manage a surge in severe respiratory intervention requirements. Assess the sustainability, the suitability and exposure, prevention and remediation protocols in order to avoid staffing impact. Third, assess medical system dependence on non-domestic commodities. Fourth, centralize epidemiology data, ensure data openness and support local and subnational tracking and tracing. And last, identify contingency treatment sites. Very little is being said around responding to the quotes above, the issue around fear, the issue around the concerns raised by the people, inclusive their own very health workers. So we realize that MHPS response is not in any form brought about in those things. And very little knowledge about the importance of responding to crisis situation is known by our government actors, or less to say, no one is there to articulate the need for it. So this is a huge gap. And until we realize what MHPS is and to understand the role it plays in holistic care, much will not be done. IFC guidelines talks about a pyramid. We are talking about integrating at all levels, not waiting until the situation presents itself before we make upward referral. Do it from the onset. And those that skips through, let's make sure we cater for them through our systems and structures. Lastly, as I conclude my 5 minutes introduction, how integrating MHPS into crisis situation? 2 key approach. The first we did in Sierra Leone, taking from the lessons we got from Ebola, was making use of informal or situational opportunities. Informal or situational opportunities. Owing to the fact that our government and other bodies are not so much interested or knowledgeable around the issues and importance of MHPS situation, when the government instituted the quarantine of people flying into our country, we make sure that we send responders at the airport in partnership with the Directorate of NCDs and Mental Health to prepare them for the quarantine. Because the resistance, the question of why should you do this to us was quite a huge challenge. The second was the fact that, I mean, the outstanding skirmishes. Somebody was talking about sending her to the holding center and nothing was being done at the end of the day. For us in Sierra Leone, there were skirmishes. People were protesting. How can you abandon us and just give us vitamin C? So those situations gave us the opportunity to voice out and justify the need of inclusion of MHPS services. And my last point under this in my closing is basically what did we do formally? Because those situational things can be one-off and it is not sustainable. What did we do formally? We pushed the Directorate of Mental Health to make their presence felt since the inception of meetings called for the response to COVID-19. Initially, she came back to us and reported that we are not valued. Even when I talk, people do not understand. But we insisted as partners that you should do it. Because until they realize the importance, they would not value you. So she kept on going and going until such a time when they say, this is important, plus the skirmishes, plus our voices. And honestly, they thought that was quite important and they buy into it. But also in the Ministry of Social Welfare, for Sierra Leone, the Ministry of Social Welfare is different from the Ministry of Health. And so we brought into the Deputy Minister of Social Welfare, who is also a professional worker and has worked out of Sierra Leone and have seen the need for MHPSS inclusion. And so these two became part of the national response team. And from those, we buy into existing structures like our mental health nurses to be included. But I must say, and I must say quite clear, there are challenges because the human workforce is inadequate. The knowledge is missing. And so even when you strengthen system, until you understand the gap and stop those gap analysis situation, the problem remains the same. This is basically an introduction, just touching from every point. And I know questions will follow and we'll be able to discuss further. Thank you, Benedict, for allowing me to talk.
Okay, Joshua, thank you for your introduction. That was excellent. Thank you very much. You really struck some very key points and share with us excellent lessons learned and strategies to help us integrate mental health. And learning from Sierra Leone, it's quite interesting actually what you shared. But I would like to move on now to Dr. Desir. So we'll come back with follow-up questions. I'm sure we are getting questions now from our audience there through the message board. Dr. Desir, same question. What is the situation of COVID in your country and your experience with integrating mental health in the response? Dr. Desir?
Yes. Good morning and good afternoon, everyone. And thank you, Benedict, for your question. And first of all, I would like to congratulate everyone for putting that webinar together so we can share our experiences with a health situation here in Haiti. And as you know, we in Haiti, we are facing multiple crises. And for example, we had on the biggest crisis we had was the earthquake we had in 2010, and where almost 300,000 people were killed. And that situation also created panic within the population. And this is why when people were worrying about COVID-19, everyone was very anxious on how that disease will be impacting the country when they are seeing and reading on the news what happened in other countries. When we consider our health situation, our health system, people were very, very afraid about that disease, including health professionals. So what we have been doing, and since then, and we do have a training for the health professional, And at the same week, when in the country, the first cases of COVID was confirmed in Haiti, we were in the middle of training for health professional on mental health. And that was a great opportunity. And so there were a gap training, average gap training for the health professional living in Leogan. And that was a very good opportunity so we can take advantage to not only provide key detailed key information about mental health and also to teach them how they need to be ready to face the coming diseases. Because as health professional, if they are anxious, how will be the population? The population will be looking at the health professional, what kind of guidance we can provide the population, how they are to be prepared for the diseases. And we got that training, the post-traumatic trainings and stress. We got that training with the health professional, and that's very helpful. And right after that, we had a team coming out to the population, mostly the affected people by lymphatic filariasis. We had 2,200 patients meeting together on a whole group. We were able to have home visit to educate them how they need to be ready about COVID-19, and that was very important. And since then, we learned that it's very important for the health sector. So health professionals need to be well prepared. Health professionals need to be well organized to help people in front to help other people facing any crisis. Because when we say we are health professionals, people are looking at us and they are looking for any advice from us. As an example, I know at a health institution, there a medical doctor who was afraid about COVID. And even in his consultation, if someone gets with fever, he just then get out of my home because I'm afraid of COVID-19. So when you, as a health professional, you thinking about like that, you are putting out people with fever because of COVID. Not all fever cases are COVID. So as a health professional, you need to be able to encourage people to come in. And this is why we think that it's very important we discuss and integrate the mental health within our protocol here at the health professional. And as we understand, health is not only absence of diseases or infirmity, it's also a mental well-being, a social well-being, and biological well-being. So most of the time, we forget about the mental health well-being, the mental well-being. I think this time, so at the high level, at the decision making, we advise to get them understand they need to take care about the mental health the same way they are providing care for the physical illness, but also if we are not mentally stable, we won't be able to receive the patient and to provide adequate care. And since then, we were being approaching by a newly unit created at the Ministry of Health to address the mental health issues. And we are in discussion to see how we, from the Cardo Center, we can work together and try to integrate the mental health into the health system as a normal practice. And at the same time, in the field, we are working with the community worker and to provide some mental health component to the population, how they can, mostly in era of COVID, we know everyone get afraid about COVID, but we need to keep working. We need to keep life working. We need to keep moving around with population. We need to understand that the disease is bad, but people are not bad. We need to protect each other. We need to encourage each other. And how we need to get that? We need to get a better understanding of the situation. And this is the work we are doing within with the population, with the community leaders, to educate them, to provide them more knowledge about COVID-19 and see how we can get a difference by taking care of those diseases and be ready for any other pandemic or crisis that may arise in country.
Okay. Thank you very much, Dr. Lucia. Again, sufficient information you place on our plate here. And I will just throw out one follow-up question to you and Joshua to respond to. Then we will open the floor to the audience. So my question is, now you talk about all your experience trying to integrate our mental health and what the challenges were and so forth. But what do you think are the most critical changes that we must make to ensure that mental health, I know, is key in any response and integration can be smooth? Sorry, Joshua, you are on mute. Yes.
Thank you. That's a brilliant question. If we have to really make those critical changes, it's like we first of all need to find out where the problem is. You cannot search for a cure for any disease you have not first diagnosed. And for me, I think one of the areas we really need to look at is our political will with regards to mental health. You know, unfortunately for us in Africa, every government has their own focus and interest, and continuing from the previous is a whole challenge. Yeah, let me cite a clear example of us reviewing our legislation, and when a new government comes, they say the process was wrong, we have to do all over again, when money have been invested into it. No donor will be happy to repeat spending on one activity twice. Until there is a political renovation of the thoughts of individuals, honestly, we are not going to do much because we feed into national documents for sustainability. So we think it's important that we have a political will. But not only that, political will also to see mental health as an essential part of health. Yeah, it's the physical, it's the social, and it's the mental. So until the perspective is changed, the action will remain the same. But another thing is the issue around budgeting. One of the speakers in the first discussion realized, spoke around no budgeting set aside for mental health and by extension for responsive situation like COVID-19. How dare, when you realize that what kills faster sometimes is the fear attached to the sickness, when the resilience is not built, when the frontline responders are themselves fearful, who can then respond? When community also lives in fear and would stigmatize because they do not have enough knowledge around the situation, who does that? For me, until government begins to show some commitment in terms of budgeting, the transformation around increased services for mental health will be an issue. But let's look around structures. I read 5 priority goals of our government. Systems and structures are what enables us to embed inclusive and incorporative approach to care. It's not a one-off programmatic thing. It would fail. It's not a responsive or a reactive thing like you fight a crisis situation, it would fail. So integrating mental health into primary care system, integrating mental health into the policies we design, not a separate document, integrating mental health into our primary health care system, even in the general hospital, will provide for the scope. So when crisis situation comes, it becomes an inclusive package because systems and structures are adequately already in place and are not done just to respond to a given situation. Maybe let me bring the 4th, then I would take a pause. The 4th here is the non-specialist to provide a service. To be sincere enough, no matter how much advocacy you do, no matter how much systems and structures are in place, no matter how much, increased commitment government make in terms of, changing their perspective, until we have trained professionals at all levels, our capacity to deliver much will be limited. Liberia may be much more better in terms of the number of people they have trained, mental health clinicians. But for us in Sierra Leone, there is this huge gap around the human resource capacity. And since the last time our project responded to, meeting the gap using the contextualized version of the MH gap, nothing more has been done. So I think the capacity ongoing should be there, and so capacity also in this context does not only limit itself to professional. We are a strong advocate for integrating mental health into our communities. And if that is so, capacitate community stakeholders and structures, the religious leaders, the teachers, every key actor in the community should be able to understand and have a clear referral pathway so as to be able to respond at the early stage. When you nip it at the bottom, it saves a lot of situation. I think these are just a few points I would want to bring. They are and ongoing, but it's just good we pick out those key ones.
Okay. Thank you very much, Joshua. Thank you. You are giving us here a very full plate. You, Dr. Desir. Dr. Desir, I think it's only fair that you respond to the question. Yes, this is why I'm laughing. First of all, to be able to get sustainability and get mental health integrated into the system, first of all, I think it's clear we as people, we understand the three components of health. Health is not only absence of disease or infirmity. We need to understand the well-being, the social well-being, the psychological well-being, and the physical well-being. When we consider all those three aspects, we'll work to make sure people are healthy. And doing that, we even as health professional, we may understand, but we need to get the decision maker understand that and take action. They need to get engaged. They need to get involved into the process. And as soon as they get involved in the process, we will through the dynamic to see how we'll be able to set up a system to get people really healthy when we consider the three aspects, the social and the psychological aspect. If we cannot guarantee the social and the psychological well-being for the population, we will be spending money in the system to provide physical care for the patient. And as soon as we were able to just be able to understand the mental part, and with the mental part, we'll get the physical diseases away, the physical illness away. So first, when we get the political people involved on, they understand, they will take decision, and then they will go to the health professional to make a training. And we understand not every health professional, they were motivated or get a clear understanding of the mental health component. And for the health professional, we get training for them to make sure that we get a team, a mental health team. When we are talking about mental health team, we need to get a social worker that will be able to work within the community with a religious leader, priest, pastor, because they do have influence in the population. When some people get some influence, sometimes they don't go straight away to the health professional. They go to the priest, they go to the pastor, they go to the priest to get advice. And if those people, they are well not integrated, they do not understand how the health is working, how the mental health, how the mental and the psychological aspect get influence, get an impact on the well-being of the population, they won't be able to guide the population properly. So I think this is a very integrated system, not only within the health, but also with other sectors within the population. And we need to get the involvement of every social aspect within the population. If we did that, we can make sure that the mental health will be integrated and it will be sustainable.
Okay, thank you very much, Dr. Desir. And now we will just jump right in to open the floor to the audience. So I have a couple of questions here from the floor. And so the first question, so I will decide who to respond to this, but it's okay for other panel members to chip in. But for the purpose of time, I would like to send it to a particular person. So this question, Dr. Juapo, I would like you to take this one. What measures do you put in to ensure that mental health issues were or are taken care of for the patients, families, and healthcare workers, considering that most people can't come out in the open due to stigma?
Okay, thank you very much, Benedict, for the question. So one of the things that we did was that we had to have, every time we even giving a result out, we had a mental health clinician work with the case investigators to give the result out. And then they found out where you live and went there to identify your home and was able to have a conversation with them at the home. And they were able to give them the lab result. Because we didn't want people, like one of the experience that, what her name is? Sadia, the one that she had when she thought that people were following her and all that. So in order to avoid those kind of, experiences, we assigned a mental health and or a psychosocial person with the case investigators. And then we went to their homes and delivered the message that they were positive at their homes so that we did not have people come back and forth. And then we assigned mental health clinicians with each of our case investigators or each of the surveillance team in our different districts. For those of you that don't know, we have 7 health districts in Monserrado County. And of the 7 health districts, 6 of those districts were, affected with the COVID. So we had mental health clinicians and psychosocial people assigned at all of these areas. We also had them assigned in the treatment unit to also continue the counseling section, even while they were there, because even in treatment unit, we had some people becoming disoriented, people refusing to eat, people develop all kinds of mental health issues, even while in the treatment unit. We had to take medication. They have some of them get on medication while even on a treatment unit. And at our different precautionary observation sites, we also had mental health clinician to go there. And when we started having a lot of community resistance, we had mental health clinician to help us to identify where people live, because someone would say, oh, I live Broad Street. When you come Broad Street, they say, oh no, I'm in Douala. So those were some of the measures that we use, because people were afraid of being stigmatized. And then the mental health clinician will call and say, hey, Dr. Juapo, can you have the ambulance to wait maybe few blocks away from where Dawson live, because he don't want the ambulance coming to his house. So we did that, and then the clinicians will walk along with them and actually escort them and have them placed in the ambulance. At one point in time, we decided to use ordinary vehicle instead of ambulances. Thank you, over to you.
Okay, thank you very much, Dr. Juapo. The next question is for Joshua. Joshua, shouldn't we stop using the word survivor, looking like stigmatizing more people? The idea of survivor does not bring the idea that people are killed. The term survivor gives other people space to imagine that maybe they didn't die, but they can still be contagious.
That's a brilliant question. The use of language, varies over time. But honestly, I think if you look at survivors from the minors, then that is also not positive. You water them down. You know, the main goal and our main goal in responding to situation is the humane aspect of the individual, is the dignity you give to them. You know, otherwise you might give all of the treatments with the wrong intention, it vitiates the entire purpose. I have been speaking and I am speaking from a point of experience because I had an episode sometime past around crisis, around mental health crisis. And honestly, those who went through and came out are more triumphant than you've been calling them survivors. And that is what affected our two local speakers, even at their community level, and most of all in the church. Because the notion of individual going through crisis situation is like it's their own fault. They are the causers. You see them as failure rather than hero. Let me bring a practical situation here. When the cases of corona in our country started, we are so much banking on the increased number rather than the increased people who came out triumphantly. And so what we did was to change the situation and say, look at the number infected, look at the number who came out triumphantly, and these are victors and ambassadors to tell you the story. That if you report early, you would be victors like them and ambassadors to speak for the well-being of all. And people were happy and they started coming out. Because what you do is you attach value to them, because most of them did not go to the shop and say, please, can you give me Corona in exchange for this? So let's change the language. It's the same around calling people mad. That's not their master status. So I would suggest that we move away from those kind of derogatory names and we move positively to enhancing their morals and show that they went through a crisis situation and they emerged victorious. I would call them victors rather than victims as well.
All right. Thank you very much, Joshua. So I will just throw out 3 questions and identify the speakers, but that will give time for the subsequent speakers to prepare their responses. So this question will go out to you, Dr. Desir. You talked about political will. Yeah, how can the ordinary people influence political will? Because at the end of the day, people go to elections or whosoever, they put in leaders and they tell them something. And at the end, they do something different. So how can the ordinary people influence political will so that we can achieve the goals we want to achieve within integrated mental health? That's one. But the other question will go to Josephine and Sadia. Josephine and Sadia. So basically, can you just tell us who do you think are the most vulnerable in terms of the impact of mental health based on their experience, and what can be done to support them? Most vulnerable persons are within the Liberian society in the context and COVID context, and what can be done to support such persons. And the last question will go out to Dr. Juapo, Dr. Desir, and Mr. Duncan. What have you seen as the most successful strategies for changing political will? Okay. For integrating MSPSS. So this one came from the group chat. So I think that's what Dr. Desir will be responding to anyway. So please, Dr. Desir, the first question on political will, then Josephine and Sadia, the question on the most vulnerable group in the society and what can be done to help them.
Thank you, Benedict, for your question. And I saw the question on the chat room and I was starting responding. So let me just speak. It's very important that the political people they have to get involved into the process, but how they will get that? And I think the most important thing, the most important way, they need to get evidence about what has been done in mental health. And when they get the evidence, and people who get the services, they know the impact of being part of the mental health strategies. And they will force the government, they will force the authorities to put these kind of services available, not only for them, but other places in the country. I think this is the way we, as mental health people, willing to document everything we are doing with evidence, and then when we meet with the political decision maker, it's just to show them the evidence, how it works, and how we'll be using those strategies will be able to improve quality of life for the population. And when the population knows and they are receiving the care, the mental health care, they will force the government and the political figure to take action to get that care integrated into the health system. Without evidence, we won't be able to convince any political people.
Okay. Josephine and Sadia, can you respond to the question?
Okay, depending on our local context or how we, let's say, identify those groups that are vulnerable, it varies. Like people have mental disorder, some adolescent mothers who are not prepared for child, they will also be vulnerable. And sometimes some parents are not able to provide for their homes, their poverty, or so, or sometimes stigma, discrimination, all make us vulnerable. So for my own context, I think those groups, we need to, let's say, support them to have them reintegrated with their parents, their parents and child relationship between them. And for, let's say, those that are also vulnerable in a sense of adolescence, probably to have job opportunity for them so that they can be able to do what they want to do. Or those groups, like some of us who survive from certain illnesses and we are placed ourselves in certain group, maybe they can connect and conduct awareness, continue to have awareness, because what we did during the Ebola time, and when it comes to the COVID-19, I still see little gap at the level. There is a little gap I still see. So we still need awareness. We still need campaign. Our people are still taking things the different way. And we need education that will be available for those that don't have. And also, like someone struck the point that to implement the policy, that is very important. We have a policy document that we work with or so, but I think we need to go back and look at it. Like Josephine and she have an eye problem and no one is concerned. So I think we need to go back to that document and revisit it and see how we can take care of these vulnerable people, or else we have a lot of people with mental issues. But sometimes when I think I never had eye problem before, I could not even use this, but when I think about it, sometimes it makes me feel bad because so what I went through before. And we should not forget about those with stigma, because the stigma is very high. I'm also encouraging each and every one of us to gather information from those reputable organizations like WHO or CDC, not to be in myth or not to give or misleading information. And the healthcare worker need to be looked after. Like me now, I volunteer at the Rawa International Airport with the team for COVID response. People come and they don't have the result. They have to go to the lab. It's not easy for them. So we all need to look in all those directions and see how we can reintegrate this mental health problem into our society and continue, because I think COVID is going to take a longer time. Like I'm seeing it, I'm not a researcher, but like I'm seeing it, it's going to take a long time. So we have a lot of work to do.
Okay, Joseph. Thank you. Sadia, quickly, can you respond to the question?
Yes. Looking at people who are vulnerable, I would say that everyone is vulnerable, because when you look at on the men's side, up to now, my husband is still traumatized because looking at his entire family being taken away and his wife being pregnant and positive with COVID-19, and he too and our other son were also tested positive for COVID-19. Up to now, he can't take his phone off silent because each time his phone rings, he will start to experience a fast heartbeat. And my children still have nightmare of ambulance come to take away their mother and then separate them from their family. I too sometimes get impatient breastfeeding my baby. I sometimes beat on her, and then some night I feel I have to say I've been taken away again. And even up to now, my husband, who is also a health worker, have been unpaid. He too had to work hard to feed his family. Both of all are health workers, and we are unpaid. There are much things that need to be done for health workers, because we are most of the time affected when it comes to disease and virus condition, because we have to go and give care to our patients and leaving our family home, going back to meet with them again. So it's very serious. The people, the government, and all those that need to come into help need to come and help people, because the social support is not there. No follow-up have been done for any one of us. I and my family, and I know other people are facing what I'm facing too. We have to go back to work, and then that need to be done.
Thank you, Sadia. Thank you, Sadia. And I think we have really run out of time, so there will be no further questions. I just want to say a big thank you to all our panel members. It has been a very interesting conversation. The sharing, very impressive, lessons learned from all sides. For the first panel, Dr. Juapo shared with us her experience as a leader in the response in Liberia. Josephine and Sadia, you share with us your experience as survivors and devoted health workers currently helping in the system. And we learned that stigma, poor mental health, trauma can be more debilitating than the virus itself. We learned about efforts made by national government to address the crisis. We learned that Ebola crisis set the stage for the preparedness, that in the early stage, government took some serious action and to promote enhanced coordination and all that. We learned that they're working with partners, and the intersectoral approach to set up the system was a good approach. However, we also know that there's a lot to be done. Mental health does not still get the attention that it needs. It does not get the support that it deserves. Lack of funding, lack of political will, they remain binding constraints. Numerous challenges and gaps still remain, and some in many areas are increasing. Mental health issues associated with COVID serious. You all have stressed that and demand adequate and sustainable support. And we learn firsthand encounter healthcare workers. I really want to say thank you to Sadia and Josephine for your very touching sharing here today. And so I would like to really express my gratitude to all of you, and to also point out how much we also learned from Dr. Desia and Joshua. You enlighten us on how working on your own experiences, integrating mental health in your response. It was another meaningful conversation with you. Joshua, you shared clearly how previous trauma is haunting and exacerbating mental health issues, and the fear of various nearby countries like Liberia and Guinea, even that put people in an unstable position. And you express how it's important to integrate mental health at all levels. This was very much highlighted throughout. You share with us some strategies, clearly. I may not be able to go through them now, but you talk about political will, we talk about holistically viewing health and not just focusing on the physical aspect, but the social as well, budgeting, structuring, the integration at all levels, and human research capacity. That came out strongly from your presentation, and training responders. And Dr. Disia, you also stress how it's important for health workers to be prepared, because if they are not prepared, then it's bad, because people look up to them for support. So in the crisis, it's important for us to initiate the processes, procedures, and activities to make sure that they are prepared. So lack of funding, again, is something that cuts across. It remains the binding constraints, and because that scarcity really affected the ability of all the management system, whether in Haiti or Sierra Leone or Liberia, to be able to address the COVID adequately and effectively. So I just want to say thank you again to all the panel members. You were excellent, a great resource for this very important event. The information you provided us is useful, informing what we do now and what we do next. And please congratulate yourself because you deserve it. It was good. And appreciation goes to our audience. Thank you for being there. Your questions were very insightful and enabled the speakers to shed light on important issues. We hope that everyone everywhere found this webinar to be very useful. And we will be looking forward to receiving feedback from you, as we will share with you a short survey. And we hope to do this more and better, but we will only be able to make that decision based on the feedback we get from you. And thank you to the organizers, to all my colleagues here at the Cardo Center who helped put this together. Thank you to our senior advisor here in Liberia and the director there in Atlanta. And the sharing of information is very important for advancing our mental health. So finally, thank you to all the partners and in mental health. Please continue doing the great job you are doing for mental health. To everyone, do have a great day. Stay safe from COVID and see you again. Over to you, Sammy.